Good evening. The curious cases of Sherlock Holmes has always excited us. In any crime scene, there will be a clue that is left behind that leads to unraveling of the mystery. In stroke cases also, there will be a clue that is usually left behind that gives a clue to the diagnosis. Welcome to Stroke Rounds 47, a curious case of stroke. 40-year-old male, young male, who has never smoked, never consumed alcohol, recently detected to be hypertensive, came with he is a driver by profession. Tiredness of 1 month, came to the ER with left hemiplegia in a confused state, drowsy for the last 3 hours. Wife says that 1 week back he had an episode of graying of vision. That's all. So this is the MRI which he brought along, done outside. This shows in the diffusion shows that there is a MCA territory infarct. You can see a opposite PCA infarct also. The ADC also shows the same. And in the flare, you can see that the PCA occipital infarct is an old infarct, and there is no significant flare changes in the MCA territory, suggesting that there is a flare diffusion mismatch. MR angio, let's read the MR angio. This is the right internal carotid angio. This is the right middle subtle artery, the inferior division, and the superior division is cut off. Even though there is the inferior division is patent, the patient has got a dense deficit and a large MCA territory evolving infarct. The patient was, since there was a flare diffusion mismatch, the patient was taken up for angiography. This is the right carotid angiogram, internal carotid artery, the distal ICA dividing into the A1 anterior cerebral artery and the middle cerebral artery. One can see the inferior division and the superior division which is abruptly cut off. The patient underwent standard thrombectomy using the Solumbra technique. An aspiration catheter was taken up through which a microcatheter was crossed across the thrombus or the occlusion. Stent retriever was deployed. You can see the stent retriever deployed, and a Solumbra technique with aspiration and stent retriever. The clot was extracted and the vessel opened completely. This is the CT scan on day 2. There is a large hypodensity there, but the mass effect doesn't seem that significant. But more importantly, there is no bleed, no hemorrhagic transformation. Now, what caused this infarct? Going through the blood report, a routine blood test showed that his D-dimer, which we are all used to now in the era of COVID, doing the D-dimer, but surprisingly, this person's D-dimer, which was done on 22nd, that is a few days back, came as more than 20,000. So that is a very, very high value. And he did not have any recent history of COVID. And he never was diagnosed to have COVID in the past also. So a D-dimer of more than 20,000 is grossly significant. And a simple Google uh, Google test showed that grossly elevated D-dimer of this level can be a sign of lung cancer. The patient underwent a CT of the thorax, which showed that there is an irregular perihilar mass like consolidation and few prominent mediastinal lymph nodes also. And there are lytic lesions in the thoracic and proximal lumbar vertebrae, all suggestive of a bronchogenic CA with metastasis. After every mechanical thrombectomy, when the femoral puncture is done, we do an ultrasound groin the next day to look for any pseudoaneurysm or any hematoma. There was no pseudoaneurysm, but there were enlarged right external iliac node and right iliac bone deposition suggestive of neoplasia or metastasis. So the MR on the day 3 showed this. There were multiple small infarcts in the cerebellum, cerebellar hemisphere. There's a large infarct in the MCA territory on the right side. Probably there is a distal ACA infarct also. And there is an opposite PCA infarct, and there are multiple small infarcts, watershed infarcts in the opposite territory. So in one of the previous stroke rounds, we had described this entity called a 3 territory sign. So this can be called a 4 territory sign. The cerebellum, middle cerebral artery, then multiple small infarcts in the watershed territory, and a PCA infarct. Three territory sign is a marker of malignancy related stroke. It is otherwise called a Trosier's sign, Trosier's syndrome, which we had described. We had described this in one of the previous stroke rounds. Please do share your thoughts, comments, opinions, and suggestions. And if you have seen similar cases, please do share your views on that. Thank you. See you next time with another episode of Stroke Rounds.